Ozempic, which contains semaglutide, and Wegovy, another semaglutide brand, have different approved uses and dose ranges. Ozempic reaches 2 milligrams weekly, while selected adults can reach 7.2 milligrams with Wegovy. That wider range is one reason Wegovy usually produces greater average weight loss in eligible adults. The advantage comes from obesity-focused dosing, not a better ingredient. Your diagnosis, access, and tolerance shape results. Both injections copy glucagon-like peptide 1, a natural gut signal released after eating. This signal lowers hunger, strengthens fullness, and slows early stomach emptying. Smaller meals may feel sufficient, while food thoughts become less urgent. The active molecule works through the same pathway in both products. Their approved uses differ. Ozempic is approved to lower blood sugar in type 2 diabetes. In certain adults, it also lowers the risk of major heart and kidney problems. Weight loss is not its main approved purpose. Wegovy is designed for long-term weight reduction in adults with obesity or overweight, plus a related health problem. Ozempic begins at 0.25 milligrams and can rise to 2 milligrams weekly. That ceiling mainly serves diabetes treatment. Wegovy uses 1.7 or 2.4 milligrams as long-term doses. The recommended 2.4 milligram dose already exceeds Ozempic's maximum. After at least 4 weeks at 2.4 milligrams, some adults may increase to 7.2. That gives doctors more room to raise the dose when more weight loss is still needed. Many people hear same ingredient and expect matching results. That comparison ignores dose, treatment length, and the patients studied. Diabetes trials often use lower doses and measure blood sugar as the main outcome. Obesity trials use higher targets and make weight change the central outcome. Same molecule does not mean same test. Consider the highest approved Ozempic dose. In one 40-week diabetes trial, adults taking 2 milligrams lost about 6.4 kilograms from roughly 100 kilograms. That equals about 6% of starting weight. For a 220-pound adult, the same percentage is approximately 14 pounds. That amount can be meaningful, even when blood sugar remains the main treatment target. In a separate 68-week obesity trial without diabetes, Wegovy 2.4 milligrams produced 14.9% average weight loss. For someone starting at 220 pounds, that is nearly 33 pounds. The result shows what obesity-focused dosing and longer treatment produced across a large study group. In a different 72-week obesity study, the newer 7.2 milligram Wegovy dose raised the average further. Participants lost 18.8%, compared with 15.5% at 2.4 milligrams in that same study. That difference is about 3 percentage points. The higher dose improved the average, but it did not double the effect. Those percentages do not create a clean head-to-head contest. The Ozempic study involved diabetes and lasted 40 weeks. The Wegovy studies focused on obesity treatment and lasted much longer. Comparing the numbers alone can exaggerate Wegovy's advantage. Study averages also hide wide personal variation. Some participants lost much more, while others lost little or stopped treatment. A 15% average cannot predict one person's exact result. Reaching and maintaining the dose strongly shapes results outside a trial. A higher approved dose does not guarantee the same weight loss across every patient group. The study without diabetes reached 18.8%, while the separate diabetes study produced a lower average. That gap shows a general pattern, not an exact amount caused by diabetes. Within the diabetes study, 7.2 milligrams produced 13.2% loss, while 2.4 milligrams produced 10.4%. That is an additional 2.8 percentage points. The dose tripled, but average weight loss increased by less than 3 percentage points. If you have diabetes, smaller weight loss does not mean weaker overall treatment. Blood sugar can improve even when the scale moves less. Weight response and diabetes control are separate outcomes, so both belong in the final judgment. Weight and blood sugar benefits still need to be balanced against side effects and what a person can tolerate. Nausea affected 39% at 7.2 milligrams, compared with 35% at 2.4 milligrams. That is 4 additional people per 100. Vomiting affected 22% versus 16%. That is 6 additional people per 100. Those symptoms often appear during dose increases. Fullness can become uncomfortable, meals can feel heavy, and constipation may disrupt normal routines. When symptoms interfere with eating, hydration, or daily activity, the planned dose may no longer be practical. The medicine with the higher approved dose can still produce a weaker real-world result. Nausea may block dose increases, and a steady lower dose can outperform a higher dose that repeatedly forces treatment pauses. Months of lower hunger and smaller portions drive the result. Whichever product fits better, do not judge it during the early low-dose phase. Those early doses mainly help the body adjust. Judge progress after reaching a tolerated long-term dose and staying there long enough. Consider weight and waist trends, hunger, portions, blood sugar when relevant, and side effects together. Side effects are not the only reason treatment stops. Insurance coverage and supply can also change which product works better in real life. Long gaps allow hunger to return and can make restarting harder. Reliable access matters because treatment works over months, not isolated injections. 4 factors shape the choice. They are the condition being treated, the highest dose you can tolerate, reliable access, and treatment without long gaps. A useful dose controls hunger without making nausea disrupt your day. The best plan also needs to continue for months rather than weeks. For obesity without diabetes, Wegovy is usually the more direct weight loss choice. Its approved doses and major trials focus on weight reduction. The recommended 2.4 milligram dose exceeds Ozempic's maximum, and selected adults may increase to 7.2 milligrams. That option can help when additional loss is needed, and the standard dose remains tolerable. For type 2 diabetes, Ozempic may fit better even when Wegovy could reduce more weight. Its approved use directly includes blood sugar control. It also has approved benefits for certain adults with heart disease or chronic kidney disease. The correct treatment solves the most important problem, not merely the largest number on a scale. When changing brands, one rule is absolute: never combine Ozempic and Wegovy because both deliver semaglutide. Neither is used with a personal or family history of medullary thyroid cancer, a rare thyroid cancer. Pregnancy guidance differs. Wegovy is stopped when pregnancy is recognized during weight loss treatment. Ozempic is considered only when expected benefits outweigh possible risk to the baby. Once those safety issues are addressed, the next question is whether a plateau truly justifies switching brands. Returning hunger and larger portions may mean the medicine is no longer controlling appetite enough. Stable appetite with slower loss may reflect lower calorie needs after weight reduction. A switch may add little unless it provides a stronger tolerable dose or fewer treatment gaps. Switching brands does not justify jumping directly to a high dose. The restart point depends on the current dose, previous side effects, and time since the last injection. After a long gap, restarting too high can trigger severe nausea or vomiting. Judge the plan after several weeks at a stable, tolerated dose. Before switching, confirm how long that dose was maintained and whether treatment gaps interrupted the response. Consider switching only when another option improves the usable dose, treatment access, or daily comfort. The goal is not the highest dose, it is the strongest plan you can continue. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.